hopefully you're adequately caffeinated now for our double bill, where we're going to talk about the various different acid-base disorders. So without further ado, I'm going to launch straight into it. So when you have a patient that has an acid-base disorder, the very first thing we do, obviously, is to assess the arterial pH. And this tells us whether a patient is acidemic or alkalemic. Remember the difference between EMEAs and OCs. So OCs are the underlying disorders of which there can be multiple. EMEAs, you can only be one thing, either acidemic or alkalemic or normal. The next question is to identify what the OCs are, what the underlying primary disorders are, and for that you need the PCO2 and the bicarbonate, often referred to as the total CO2 in the serum. I show here the Henderson-Hasselbalch equation. You don't actually need the equation for the boards, but I show it because it helps to, at least for me, to visualize why the bicarb and the PCO2 do what they do in the various disorders. So as you can see here, the pH is 6.1 plus the log of the bicarb over the 0.03 times the PCO2. So what this tells you is that when the bicarb goes up, because it's in the numerator, pH goes up. When the PCO2 goes up, the opposite happens, pH goes down. And from that, we get this, which we're very familiar with, that a low bicarb indicates a metabolic acidosis, high PCO2 respiratory acidosis, etc. But interpreted in the context of the arterial pH, whether it's acidemic or alkalemic. And then the third part is then to determine whether there is a normal or abnormal compensatory response to that acid-base disturbance. So all acid-base disturbances elicit a compensatory response where the body, meaning the respiratory apparatus and the kidney, attempts to partially correct that back to normal and try and minimize pH disturbances. And so determining the magnitude and direction of the compensatory response is critical here. So I have some slides here that are in sort of a pale yellow color. These refer to things that you do not need to memorize, but are shown here for your information. If you need to know these things, you carry them either on your iPhone or on a card in your pocket. But you should know how to use them. And so in the setting of a metabolic acidosis, of course, we respond by hyperventilating to bring down our PCO2. And the expected response for every milliequivalent per liter decrease in bicarb is a 1.2 millimeters of mercury decrease in PCO2. And that's a fairly reliable and fairly rapid compensatory response. Metabolic alkalosis, the opposite. Less reliable because there's a limit to how much the PCO2 is going to go up before you get respiratory drive to breathe faster. And then in respiratory acidosis and alkalosis, the kidney responds by regulating how much bicarb is excreted. And here, the important thing is that in an acute respiratory disorder, the compensation is less, usually in the first 3 to 5 days, and it takes quite a few days for the kidney to adequately respond. So a maximum renal response to a respiratory acidosis is 0.3 milliequivalents per liter rise in bicarb for every 1 millimeter rise in PCO2, but it takes a while. So in acute respiratory acidosis, you might expect less. And the reverse is true for respiratory alkalosis.